This program is a presentation of UCTD for educational and non-commercial use only.
Our final presentation this afternoon will be from Christine Yaffe. She is she's the Scola Endowed Chair and Professor of Psychiatry, Neurology, and Epidemiology. She's also the Chief of Geriatric Psychiatry and the Director of the Memory Disorders Clinic at the VA. Her research work deals with a wide range of cognitive disorders and geriatric neuropsychiatric conditions, and I believe she considers herself an epidemiologist as her first calling. We don't have enough epidemiologists in clinical medicine or neuropsychologists. I think this whole effort benefits from different trainings and perspectives. So with that, we'll invite Christine to come up.
Well, thank you very much, and thank you for enduring on this beautiful day the dark but fascinating material. And I hope I'm sort of the caboose here. I actually want to thank Dr. Mays and the organizers, because I think we should be doing more of this kind of thing. I mean, it's so multidisciplinary and so interesting, and it's really been a great afternoon. I'm going to, I think, talk about something that's complementary and we haven't heard that much about, and that is sort of how chronic medical diseases, particularly metabolic diseases, might interface with what we've been hearing in terms of cognitive aging. And I think we were talking at the break that one of the things that could come out of this, I think, really nicely is that this risk stratification that we're hearing either from Bill's work that you could do different sort of network imaging, you could do certain neuropsych testing. But I think you could do biomarkers, but we also can look at some of the person's comorbidities, and I think all of these together really could teach us a lot about who's at risk for this POCD. Okay, so why might we be interested in metabolic diseases and cognition? Well, first of all, they can tell us a bit about the mechanisms of dementia, and I think in particular we've seen this with diabetes. I think this whole link with diabetes and cognition, which I'll talk about, has been really fascinating. Similar findings for hyperlipidemia, for example, and mechanisms of beta amyloid. We also might come up with strategies for prevention. So if you know something's associated, you might try and screen and prevent. There are also important implications with our patients who have a lot of medical problems. We get a lot of referrals, for example. This person has 10 medical comorbidities, and we've noticed that they're not taking their medications. Maybe they have a cognitive problem. So, there is a circular route here. And we know that aging is a very complex multi-system process. So what I'd like to focus and very briefly go over 4 very interesting metabolic diseases and how they may be connected to dementia and cognitive aging. And that's diabetes, obesity, the metabolic syndrome or sort of accumulated cardiovascular disease risks, and chronic kidney disease. So what about diabetes? I mentioned this, that there have been some fascinating links with diabetes and the underpinnings of dementia, in particular AD. We know there are insulin receptors in the brain. We know that the IDE, or the insulin degrading enzyme, not only regulates insulin, as the name implies, but actually is one of the key regulators of beta amyloid levels in the CNS. So really complex interaction there. Some people think that Alzheimer's is type 3 diabetes. I think that's a bit of a stretch, but the point's well taken. But we do understand that insulin resistance has an important role in AD pathology. We heard a bit from some of the talks before about RAGEs, and so there's fascinating interactions. There's a PPAR gamma is an important metabolic pathway, and it's a protein that regulates metabolism, and there's been a lot of interest in PPAR gamma agonists and how they may affect insulin sensitivity and cognition. although some disappointing trials, as Leonard indicated a little while ago. We also know there are important inflammation changes, which would link, as we've been talking about all afternoon, and of course very important changes in micro and macrovascular disease. And this is sort of highlighted in this diagram. Changes in inflammation and age, the advanced glycosylated proteins, insulin changes, as we talked about, having a direct effect on beta amyloid, and the micro and macular vascular changes. All of this could accelerate cognitive aging and, of course, lead to AD per se. This is some work from Suzanne Kraft's group. Suzanne Kraft has done some very interesting work with diabetes and insulin in terms of beta amyloid. And you can see that there's a, not great, but this is a small sample, pretty nice association between CSF changes in beta amyloid with exposure to insulin. So there's really this interesting connection, again, between insulin. In this case, they actually put it into the CSF, and also there seems to be changes with age. This is some work from many, many years looking at just observational studies of diabetes. So big cohort studies, primarily some case control studies, looking at exposure of diabetes and then incident MCI or incident AD or vascular dementia. And I think just to orient you, these are odds ratios, so this is 1. Anything to the I guess your right here is a higher risk. Anything to the left is a lower risk. And I don't think it takes, much effort to see that the preponderance of evidence suggests that having diabetes increases your risk of dementia of all flavors, whether it's AD, MCI, or vascular. Of course, there are publication biases, and people don't publish negative findings, but nonetheless, I think it's pretty compelling that there's something going on. So we've been interested in this, and we're sort of fascinated by what this could be and sorting it out. And our thinking was, well, if it's really diabetes, if it's really the glucose per se, we should see something with markers of glucose. So we undertook a couple studies looking at those at risk either because they were pre-diabetics, impaired fasting glucose, or because they had high glycosylated hemoglobin, which is a common marker of one's glucose control, particularly in the setting of diabetes. And so this is the first study that's now actually not so recent, but what we found is that in an older cohort of women, we found that it wasn't just diabetes that increased the risk about 2-fold to have cognitive impairment, in this case MCI and dementia, but it was also this impaired fasting glucose. This pre-diabetes had almost as increased of a risk. And this was actually the first report that found this association with impaired fasting glucose, suggesting that it might not just be the comorbidities and vascular disease, but there may be something actually about the glucose itself, because this pre-group was at risk as well. This didn't quite come out as well, but and then in a similar study, what we did was we looked at again this HbA1c and to see whether this was associated again with MCI and dementia, and we found, and this is really interesting, keep in mind these are not people with diabetes by and large, so most of these are without diabetes, and just looking at just a hemoglobin A1c per 1%, which is not much, you can see some very increased risks, 30–40% increased risk of dementia and MCI. So again, non-diabetic, so suggesting that there may be something about having high glucose that is causative, and it's not just further down diabetes with lots of complications. This is our common cutoff among diabetics. We look at a level of 7 usually to see if they're well controlled or not. So this is using this, and when we use a marker of 7, you can see it's much higher, so risks of 4-fold, not just 30%, but much higher. So what can we say about diabetes and dementia? I think, you know, the preponderance, the vast preponderance suggests there really is a very important relationship between these two diseases. Maybe stronger in vascular, I didn't get into that, versus AD, but I think increasingly we know that this is important in both pathologies, and that markers of glucose probably are involved as well, suggesting it's not just downstream effects. I think we need better trials aimed at treating diabetes and those at risk. Unfortunately, this has been another area where we've been disappointed in terms of the PPAR gamma agonists have not worked out and in fact cause a lot of harm in the setting of rosiglitazone. Pioglitazone is now being studied in some other studies, but I think there's recently there was a RAGE trial for Alzheimer's disease, and that's now been stopped for futility. So we're not doing so well, but I think it's going to be a very rich area for further study. Obesity, another very important and increasing in our country problem, in that many states have a very high, you know, 1/5 to 1/4 of the population with obesity, not just being overweight, but obese. So this is, and of course this is increasing. So we need to be paying attention to this. There's a lot of work to suggest that midlife obesity, in this case just measured with a BMI, so nothing fancy, suggests that there's an increased risk of dementia in a very nice dose effect here. And some work by Bill Jagus suggesting that there might be in late life an association with the waist-hip ratio, which again is sort of a cheap way to look at obesity, but very predictive, and in this case associated with hippocampal volume. So we were interested in this question, and with some colleagues at Kaiser, we looked at whether midlife obesity, in this case measured a little differently, either as a sagittal abdominal diameter or a thigh diameter, thigh circumference, whether this was associated with later risk of dementia. And what we found, if you concentrate really on these two sections of the graph, you see that this is the SAD, so middle, the apple versus pear, it being obese in sort of this apple form is really bad, and with marked increase in having dementia in late life. Whereas if you're just heavy all around and measured with the thigh, you don't have an increased risk. And this was true in this line when we adjusted for BMI. So there's something about this central adiposity that is especially bad, which we know from cardiovascular disease as well. So there's something going on here in the brain. And we then looked further in a large cohort of non-demented elders. We looked at this issue very carefully by actually regional measurements. So these are radiographic measurements using CT scans by and large, DEXA measurements. And what we found, and it's a little hard to see, but what we found by looking at either the BMI, the different fat tertiles, abdominal fat, total fat, what you can see is stratified by men and women, that in men, interestingly, and these are all older, so it's not midlife, it's late life, in older adults, having high amount of fat in a number of different places seems to increase your risk of cognitive decline in men, but not in women. So there's an interesting gender difference in late life that others have shown. Framingham actually showed a sort of similar but different strategy, and showed again there's this interesting gender effect. So we were interested to see whether this was hormones. You know, it could be hormones, it could be changes in a number of different things. And we looked at those, including adipocytokines, and actually this finding in this gender interaction remains. So I think an interesting thing to explore. Measuring body mass and the changes in terms of your muscle mass versus fat is very complex in the elderly. So I think at this point the evidence is predominantly in midlife. The midlife obesity certainly seems to be a risk factor for late life. Late life obesity, I think, is trickier, and maybe with this interesting gender interaction. But I think we need to remember that fat is not an inert substance. Fat is a very powerful organ that actually secretes a lot of problems, and in particular inflammatory factors and adipocytokines that actually could have a direct effect on cognition. There are also downstream effects in terms of dyslipidemia and hypertension, but I think there are some interesting direct factors. This is one of them that I think we need a lot more study on, and that's serum leptin. There's some really interesting animal models showing that leptin and A-beta are associated, but surprising little work in humans. So we looked at this issue about whether leptin actually, and leptin is produced primarily by fat, was associated with cognitive impairment. And we found, in fact, having high leptin was favorable. And this was then replicated, I think, last year by the Framingham group. So I think we may see a lot more on leptin. I think actually there's a group that's doing a randomized controlled trial of leptin as well. So I think we will see more about this. And similarly, PPAR gamma. I mentioned this, that PPAR gamma is very important for metabolism. Despite some really interesting early starts in pilot trials, we now have had some big trials that haven't worked out. But nonetheless, I think we're going to learn more about PPAR gamma and if modulation of PPAR gamma could affect cognition in addition to cardiovascular disease, et cetera. We were interested in whether there's a common polymorphism in PPAR gamma, the Pro12-ALA variant, and we were interested in whether this variant could have affected cognitive decline, and in fact we found it did, that if you had the ALA allele, you actually had higher baseline and less decline over time, and also less impairment, cognitive impairment, which we defined as a dichotomous outcome of 1.5 standard deviations. So all of this to say that I think the role of obesity and diabetes in the brain, I think, is really a fascinating area. There's some really interesting animal models to suggest the pathways, and I think we're going to learn more and more about this. It's really funny, when we published this finding on the central obesity, this cartoon came out, which was very funny, and that it's sort of political but relevant cartoon. I'd like to now turn to something related but slightly different, and that is how one can look at composite or multiple cardiovascular risk factors and dementia risk. And we think that, first of all, these risk factors tend to clump together. So if somebody has hypertension, they may also have diabetes, they may have dyslipidemia, they may be obese, and so they do tend to clump together, often in the metabolic syndrome, which I'll talk about. But we also think that they may have some interesting interactions with ApoE. Mary Han published this a while ago, and others have now followed up on that. The other thing that's kind of neat about this idea is that not only do they co-occur, but you can then identify individuals at risk. And this might be a group to try and target and modify. And I think the Europeans are ahead of us in this, and that they're trying many multi-domain trials now, and one of them is cardiovascular risk reduction, often with a case manager who can affect many of these at once. So this is just some graphs on the common prevalence of metabolic syndrome. Metabolic syndrome is this constellation of many of these risk factors. And you can just see really that the couple findings of note. One, it's very common, so increases with age. But in some different ethnic groups, I mean, you're looking at 50% have metabolic syndrome. So some interesting ethnic differences, particularly high in the Mexican American group, which we'll talk a bit about, and high with age, and maybe higher with women. So we were interested in this question about the metabolic syndrome because we know it's associated with all these bad cardiovascular outcomes, but actually very few had really looked at cognition as an outcome, and yet we knew that the individual pieces were associated. So our definition was basically the standard NCEP guideline of having big middle, poor lipid profile with triglycerides and HDL, blood being either hypertensive or being on a medication, and having impaired fasting glucose, or again being on a medication. And what we found, and again I think relevance to what we've been hearing today, is that those elderly, non-demented elderly who had metabolic syndrome did have an increased risk, but it was particularly so for those with high inflammation. And this is important because in the cardiovascular world, this has been shown that there's this very interesting interaction with inflammation and metabolic syndrome on adverse outcomes. And some, in fact, have suggested that the metabolic syndrome might include inflammation in its definition. So we found this really interesting, and this was a significant interaction, suggesting that metabolic syndrome is bad, but it's particularly bad if you had a high inflammation. In this case, it was CRP and TNF-alpha. We actually followed up on this in the SALSA cohort, and I don't know if Mary Hahn's still here, but she's the PI of this cohort. It's an interesting cohort of elderly Latinos. And so we were interested in this cohort in particular because I showed you that the prevalence in metabolic syndrome is so high. And we were interested to see whether this interaction with inflammation would bear out. And it really did. So these are just beta and p-values, but you can see that having the metabolic syndrome did increase risk of cognitive decline. This is slope of decline. But it was particularly so, again, having a high CRP. And so there really was this, again, this sort of interesting interaction. And some colleagues in Europe now have found this as well. So I think this interaction with inflammation and metabolic syndrome is bearing out. And what's interesting is it's true across several cohorts and across several different ethnic groups. So I just want to lastly take a few minutes to talk about kidney disease, which I think is very interesting and becoming much more, I think, recognized that this is an important thing to study vis-a-vis the brain. Kidney disease has not been really looked at very closely in terms of cognition, other than more in this sort of delirium encephalopathy mode that's often around the dialysis. But I think people are starting to understand that you know, both kidney disease and cognitive disorders increase with age, and there are a lot of commingling factors, hypertension, diabetes, of course, and that there are some other specific kidney-focused things that might be very important, like uremic solutes. Ages seem to go up as well. So I think this is a really interesting and growing area of study. Manju Kurella Tamura, who's now at Stanford, but was a postdoc with me, we looked at this question about kidney disease and cognition in a cohort a large cohort of elders, and we found that cross-sectionally having GFR really did seem to be associated with, in this case, a global cognitive score. And then she's now published some beautiful work showing that this is really true in dialysis as well. And in fact, she's undertaken a frequent dialysis trial to see whether if you have dialysis more frequently, this affects cognition. But together we also we've assembled a cohort of over 800 elders with CKD, and we're now studying them longitudinally to see whether they have increased rate of cognitive decline and what the mechanism might be. And this is just the cross-sectional results, which basically confirms what we'd been finding, but few had really looked at different domains. And what we found is that indeed GFR is associated with lower GFR with worse cognition across all domains, and that it's also associated with impairment. So in this case, the reference is the eGFR of 45 to 60, and you can see that here increased risk of cognitive impairment and sort of a nice dose effect again with lower GFR. So I think this is another area of we're going to see a lot more about. I just want to end with this slide, which is another maybe biomarker that I'd love to see more on, and that is cystatin C. So cystatin C is a much better marker of kidney function. It doesn't, particularly in the elderly, because it doesn't involve BMI and the changes that we talked about in terms of muscle mass in the elderly. And so there's been a lot of work on cystatin C as a better marker of kidney disease, and yet there's also some interesting models of cystatin C and cystatin C polymorphisms in terms of Alzheimer's disease. So we've found that cystatin C seems to actually be an interesting independent risk of cognitive impairment and decline, even when you adjust for GFR and comorbidity. So I think this is another area we'll see a lot more about in connecting kidney disease. So I just want to end by saying the brain and the body are both important, and that we're seeing that today. But many chronic diseases, especially the metabolic ones, I think are very important to cognitive aging and cardiovascular disease as well. And I think that we need to really understand this link better and think about this group, particularly when we do risk stratification, possibly even in terms of post-operative cognitive impairment. So thank you all, and thank my support. Thank you.